Good evening friends. In this video I am going to show some basic techniques in FESS. This is a case of left-sided pansinusitis with minimal polypoidal changes. I also did conchoplasty for the conchobullosa to improve the access for the middle meatus. I have the habit of doing septoplasty first to correct the high DNS if any to improve the access to the middle meatus. Our first step of the FESS starts by down fracturing of the inferior turbinate or lateralizing it. In this case, I also done partial inferior turbinectomy, which also improves the access to the middle meatus. In a FESS, my main instrument is J-curate. I use a J-curate for doing MMA. See here, I am just trying to penetrate the J-curate at the nix point, that is, at the junction of the vertical and horizontal parts of the uncinate process. Remember, this is a safe technique only if you are perfectly oriented with the anatomy. If you dip the J-curate at an inappropriate place, you may land up in orbital emphysema. Once I dip the J-curate, I swing inferiorly and superiorly around the maxillary ostium. Now I am cutting the uncinate process with a turbinectomy scissors, one cut inferiorly, one cut superiorly. I am removing the middle part with a upturned black scissors. Now I am passing the J-curate into the infundibulum and I am pulling the uncinate process anteriorly. While doing this, I am seeing the tip of the J-curate through the uncinate process. Though it appears a blind technique, but I am still seeing the tip of the J-curate behind the uncinate process. Now I can remove the anteriorized uncinate process with an upturned Blake sleeve or a debrider. Margins of the middle metal antrostomy are regularized with a debrider. Now we are left with middle turbinate with ethmoidal bulla. I am passing the J-curate between the middle turbinate and the ethmoidal bulla into the retrobullar space. I am then pulling the bulla anteriorly. Here also again I am keeping in view of the tip of the J-curate and also the level of the skull base. If you are careful enough, this is very simple. Anterior ethmoidectomy is done in one single go. Now we are seeing the vertical part of the ground lamella supporting the middle turbinate to the skull base and lateral wall, and the horizontal part of the ground lamella supporting the middle turbinate to the lateral nasal wall. Now we are proceeding to posterior ethmoidectomy. For that, we are just piercing through the ground lamella in the inferomedial part. I am using a Freer's elevator and I am just using the same instrument to break the septa and make it into a single large cavity. Now the intersinus septa are removed with a upturn or stride Blake sleeve forceps, or you can debride them. Now I am passing medial to the middle turbinate so that I could see the superior turbinate and also the sphenoid ostium. If you are worried about destabilizing middle turbinate by going medial to the middle turbinate, you can go lateral to it middle turbinate, and you can identify the superior turbinate just after piercing the vertical part of the ground lamella. I prefer intermediate technique where I sacrifice a part of the superior turbinate by cutting it with a turbinectomy scissors. Cutting in between is a good idea to achieve hemostasis. Stump of the superior turbinate is debrided, sphenoid sinus ostium identified, and again a Freer's elevator is passed and the ostium is widened. Sphenoid sinus ostium debrided and made into wide. Here we are not stripping off the undiseased mucosa. Thereby we are doing mucosa preservation technique. We are stripping off the diseased or polypoidal mucosa. Thereby, we are allowing it to reboot. I recommend all the juniors not to debride in the interior of the sphenoid sinus. Your territory ends only at the level of sphenoid ostium. Any contents in the sphenoid sinus should be sucked out, or with a good wash they should come out. Gentle wash is given in the sphenoid sinus. There are many ways to expose the frontal recess. It could be axillary flap technique, intact bullard technique, or Weigand's technique, which I am showing here. I have the habit of opening the frontal recess in the end. So only after exposing the or delineating the complete skull base. Axilla of the middle terminate is a good landmark for guiding us to the frontal recess. You all know frontal drainage pathway can be medial or lateral to the uncinate process. Again, I use my friend J curate by just passing it in between the middle terminate to the roof. Identifying the frontal beak, slowly I go posterior, and as I reach the frontal recess, if there is any uncinate process, I'll just lateralize it and I reach the frontal recess. Frontal recess is exactly behind the frontal beak. So once you are palpating the frontal beak, at the moment where you lost the hard bone, it is frontal recess. Now I use a 120 rad to trim off the polypoidal mucosa in the frontal recess. You can also use a 60 rad depending upon the surgeon's comfort. You see polypoidal mucosa is coming through the sinus. As I am doing this case under general anesthesia, I have the luxury of giving a wash in all the sinuses. Gentle wash is given in the frontal recess. In the end, after achieving the hemostasis, I keep a gel net piece in the middle meatus so that a part of it still peeps out through the middle meatus, so that even if the middle terminate lateralizes, it doesn't stick to the lateral wall. Nasal cavity is packed. Thanks for watching.